So Tessa is a certified substance abuse counselor, brings a client-centered, trauma-sensitive, and harm reduction approach to their work. They've worked for over 10 years with individuals involved in the criminal justice system, the queer community, and those who are unhoused, with a focus on substance use care. Active member of DUHAC, the Drug User Health Advisory Committee of Santa Clara County, and is passionate about making sure marginalized communities have a say in the care they receive. The Harm ReduQion Project offers queer, affirming, trauma-centered substance use and overdose prevention, education, and resources. They provide NARCAN training, access to NARCAN, fentanyl testing strips, and safer sex supplies. Tessa will introduce the program, provide information about harm reduction, and teach folks how to use naloxone, I'm really massacring that, and NARCAN. So turning it over to Tessa.
I work at the Q Corner, which is now called the Collective, because we have joined services under our umbrella of services. There has been added a gender affirming care clinics. This is a specialty mental health clinic for trans, non-binary, and gender diverse folks that are on Medi-Cal or uninsured. It will see patients 5 and up. So they are a clinical mental health service provider. We, as the Q Corner and the Harm ReduQion Project, we have peer supportive services. We have a lot of peer support groups. We do, supporting folks with their name and gender marker, which I'll put a ping in. There's an event Santa Clara County is putting on City Hall, I believe next week or the following week, where they're going to give out certificates to folks that have legally changed their gender marker or name at City Hall. I believe Susan Ellenberg's going to be there helping out with that, but don't quote me on that. That's an assumption, which I should make. But anyway, so we do a lot of supportive services. Most recently, we're going to start doing a harm reduction group in custody, working with folks in the LGBTQ plus community that are incarcerated. And another one that I really love to share about, which is kind of unique, is it's a organization called Oasis Berkeley. They're a legal service, and they work with folks seeking asylum for LGBTQ rights in America. So folks can come into our space and we can link them up virtually with a lawyer to see if they can take their case and help represent them in terms of, seeking safety in our sanctuary state, I think we're called. And then, so we just do a lot of great services. We have a drop-in center. That's really like the meat of our program, is folks can come and drop in, very similar to here. We do have limited hours during business hours. Our drop-in hours to 5. Anyone can come in. Allies, providers, parents seeking service, just support. Anyone will serve and make sure. So the Harm ReduQion Project specifically, like Cheryl talked about, that was created because of the understanding of the intersection between LGBTQ plus folks being unhoused and substance use, right? And really understanding that we aren't going to change people and how they're living their lives, that we're going to meet them where they're at and really support them. And, if they want different types of services, like let's say going into treatment or whatnot, our job in my project is really going into those services and making sure they're affirming, right? I'm not going to send a trans woman to Mariposa if I don't know they're going to treat this person with respect. And you know what I mean? Because we work with a lot of folks, we're in the community. There's a lot of trauma and pain within our community, right? So that's been the really hard part for us at the Q Corner. And that's honestly why the Q Corner came about, is because there was a survey within Santa Clara County. I want to say about 2008, it was like a community needs survey, and the highest percentage of folks in the LGBTQ plus community were seeking services outside of our county, because we didn't have affirming services, right? This place existed, yes, for DeFrank, but in terms of like county system services, where can I get gender affirming care? Where can I get mental health care? So folks, go to the city or go to Santa Cruz and other counties. So that really brought the attention to the county systems, that gap in service for the community, right? So the county then initiated the LGBTQ Office of Affairs, which they do more of like the brick and mortar, right? They're the ones that will say, hey, you need to put a sign on your single stall bathroom that's for all folks, right? The non-gendered bathroom and those kind of things. So they're kind of in the background really doing policies and working with, schools and implementing that. Where are the client facing, or excuse me, the participant facing program, where folks come in, we can get peer support, we can hang out, we can really, just be and have a space where folks can just be fully accepted. So I do have a lot of flyers. There's a lot because we do a lot of services. One thing we really love is trainings. We have a really amazing training team. We get trainers from all over the states, and things like clinical work with sex workers, right? Clinical work with neurodivergent queerness, trans affirming care. We're doing one on Thursday that's going to be reproductive health for trans, non-binary, and gender diverse folks, right? So we have a really, but the thing is, we need people to take our training so they can get the understanding on how to serve, you know, our community better and be an ally and a participant and not gatekeeping care. Very similar to your y'all's mission, right? Of really just being in community and helping. So I'm very honored to be here and coming into such an intimate space and, you know, being allowed to be a honorary member for the night now. But thank you so much. So I'll move to the next slide following my introduction. Thank you. And then, so this is the flyer of the Harm Reduction Project. So you can kind of see a visual of the things we do, support, education. That's where I'm doing, like today I did a all-day training with public health and others to help permanent supportive housing folks get harm reduction support. And we do a lot of connecting, right? That's where folks will come in. I want to vet out services within our community to make sure, you know, that they're affirming and making sure we have awesome people for them to catch them when they come in. So feel free to come and drop in anytime you'd like. The address isn't on this one, but it is on the others. But thank you. I'll go to the next slide. So what is harm reduction, right? We're hearing this all around. I'm hoping you're hearing it. Harm reduction is not new. And it is when we look at it in the terms of substance use, it's really about meeting people where they're at, not trying to coercively change, right? So I have two examples of definitions up there, which are a little wordy, but the reality of it is non-barrier access, meeting people where they're at, understanding there's different stages of use, managed use, abstinence, chaotic use, really helping folks just authentically as they are. Within harm reduction, it's really about trying to reduce the harm in that immediate moment, right? I'm not looking to, when are you gonna go to treatment? I'm looking to, are you using fentanyl test strips to test your substances before you're taking them right now because we're having a fentanyl crisis, and, you know, really things that are pragmatic in that moment and building connection. I use these two because National Harm Reduction Coalition did the top one, which obviously by their name, you can tell they're very harm reduction forward. And SAMHSA has also started to really embrace harm reduction because there's been kind of a historical thing. It's harm reduction or abstinence, and that is not true, right? That's like that binary thinking. There's this or that. That's like us as humans, right? Where does non-binary fit in, male or female, right? So it's really that understanding that people use all different ways. It isn't you're addicted or you're not addicted to substances. I'm sure there's people in this room that use substances that aren't addicted, but they're using substances, right? So it's really looking at recovery is a completely individualized journey for everyone, right? As a healthcare provider, do I believe maybe abstinence might be the best for some folks? Yeah. Do I get to force someone to make that change in their, you know, have we ever tried to change someone in this room? How did it work, right? We got a lot of pushback, right? But we can help change ourselves. That's really, you know, a more unique way to work with someone is client directed, right? What do you need? What do you want? Not you need to do this in order to get X, Y, and Z. So when we look at it, if you look at this little Maslow's hierarchy of need, the very bottom one is the psychological, and that talks about, yes, physiological, sorry. So that's where we have breathing, which NARCAN keeps people breathing, right? We have food, shelter, hygiene, really those basic needs. So when we think about somebody that's living unhoused, when they want to go to detox or withdrawal management, how are they going to get there if no one's engaging with them? If somebody's outside these doors right now and they're like, okay, I'm done with this, like, I want to go to treatment. Anyone know how they're going to start that journey, right? If someone like you or me is checking on this, hey, how you doing today? I got NARCAN, you want it? Okay, cool. At one point, you know, and sometime this person says, you know, I'm done with this. Can you help me get to treat? Yeah, we can help you, right? So that ability to be with people exactly how they are and not try to say, you need to do this in order for me to care for you, right? Which I see a lot in our abstinence-based treatments, and trust me, I'm not knocking them because a lot of folks benefit from it. But then what happens if we're in an abstinence-based treatment? You use substances, you're usually kicked out. You're not, hey, let's give you more time. Let's help you with this issue you came in to address. We say, no, we reject you. What comes up is shame, rejection, isolation, right? All these things. So this approach is meeting folks exactly where they're at, working with them when they're under the influence, if that's what they want, you know, and just really helping them. We are right across the street from our sexual health and harm reduction program by the public health department, where they offer naloxone testing strips, they offer safe use supplies. Like there's so much going on in our county to help people that use drugs. for instance, I wear shirts like this, right? I love people that use drugs, right? Because I know the stigma attached with substance use. And I know that that stigma keeps people from asking for help. It keeps people isolated. It keeps them, you know, indoors, alone. And so when we look at what are the elements of harm reduction, it's about like collaboration, respect, compassion, empowerment. And when I look at collaboration, yes, we can collaborate as providers, right, or systems of care, but I'm talking about collaborating with the participant, right? What do you want to do with your life? How can I support you with that, right? And not, again, putting my ideals on and really just stepping back and making connection with folks non-judgmentally and just being there, right? We can move to the next slide, so I'll get more into good stuff here. So when we look at who practices harm reduction, it might surprise you because you do, your kids do, your parents, if they're with us, do, your grandparents hopefully do, I did, coworkers do. So these are examples, right, of what harm reduction is outside of substance use as well with substance use, right? So it's about, like I said, reducing that immediate harm in any activity. So if we are out in the sun, we want to put sunscreen on. So we understand that reduces harm in our skin, right? If we are driving, we want to put our seatbelt on because the impact, right? So we have all of these things that we endorse in our communities, right? We want speed limits. The very first harm reduction practice I learned was putting headlights on a car. It had nothing to do with substance use. It had to do with safely driving your automobile when they were produced, right? Who would have thought of that? How'd you find that out? I drove in the dark and, oh no, we need something to reduce the harm of these folks driving, right? When the sun goes down. So it's really, what I think happened is the controversy came when it was with substance use, and there's so much stigma and legality and criminality around substance use that harm reduction is not endorsed. But again, it's been here in the 21st century forever in terms of practicing designated drivers. On heavy drinking nights, I see free transportation because we understand how, you know, to reduce that harm for people to be under the influence out there. We have eliminating certain foods in your diet. If you're pre-diabetic or you have gluten tolerant, you're changing your diet, that is harm reduction because that reduces the harm in your body, right? We get a little more controversial when we start looking at these next ones below. Medication assisted treatment, right? I always hear, why would you switch one substance for another? Well, what if someone's taking methadone, they're going to work again, they're paying their bills, they're taking care of their children. That's not for me to say, you're not really that sober and this doesn't, you know, work. That's their life. Look at the quality of life that's increasing. Hormone replacement therapy is harm reduction, right? You know, a trans person gets cut off of their hormones, how their biology is so affected, right? And what else we incorporate in harm reduction, I'm going to skew from the list a little bit, is like that public health model and that mutual aid model, right? So when I use that example, I always think of, you know, I know folks in the trans community, they have stored extra hormones because we know that this gatekeeping happens and all of a sudden someone's insurance says, you are not a 65-year-old cisgender woman. I can't prescribe you this. How am I getting this medication for this? You know, so then what happens? Mutual aid, a friend or a colleague says, hey, I got you till you can get your prescription, right? So there was a lot of that happening in harm reduction work because the systems that we made weren't really seeing the LGBTQ plus community, the BIPOC community, right? They weren't able to access care in these systems. So they were helping each other out, you know, finding their own way to care for each other. So that's a huge part, you know, that really, human to human approach of really connecting with someone and just offering support. When we go further down, safe consumption sites, right? These have been very, we don't want these here. Why would we let somebody come into an establishment and safely use substances? We do. They're called bars. We have safe consumption sites in our country, right? But we're so adverse to wanting somebody that's using opioids or somebody that's using another drug to be able to go into an establishment and safely use it. And the only reason that really is controversial, it has to do with the war on drugs and racism, right? When we look at substances, this really isn't about science, why they're illegal, the impact on the body, why they're illegal. It's about who is perceived historically to use these substances, and that's how they became legal. There is no reason we know, hopefully collectively, that alcohol and nicotine kill more people every day in our country, even with the fentanyl crisis, than all the other drugs combined. So why are they illegal? And it's not because they're legal and people can get accessibility to them more. Historically, in the war on drugs, what happened was when the Nixon administration came, well, even further to that, prior to that, in the Harrison Act, it was the first time in like 1914, they ended up regulating opioids. And that was 30 years after Chinese immigrants came into our country. What did Chinese immigrants bring? They brought opium. They had opium dens. They did this. So we cannot enslave folks because we had abolished slavery, right? So instead of saying, do what you're gonna, and it wasn't mass overdoses and substance use and all the things that we see in today's day. It was, okay, so if they're using this substance, we regulate it. A, we can make money off of it, and B, we can criminalize folks that try to use it outside of regulation. So then we went down that ladder, and who's associated to use crack and cocaine? African American Black folks. So we legalized that. Who's associated with cannabis? Migrant Mexican workers. So we legalized that, because I'm sure we know that alcohol and marijuana are two very different substances, right? And marijuana is actually classified as a Schedule I drug that is no medical purpose and highly addictive. And then we have alcohol, so it's like when we're looking at these and when we know that, why is alcohol legal? The colonizers, the Anglos brought it to this country, brought it to this land. What happened? Prohibition. What happened? Folks started making brews, they started underground moonshines. People started dying. They were drinking this toxic alcohol, right? White people started dying. So what did we do? We said, oh, no, we can't have that. We're gonna have 21st Amendment, and that's where we brought alcohol back in and we regulated it. That's exactly what's happening right now with the fentanyl crisis. It has to do with a certain type of person that's using it. So we're not changing, if this was an alcohol related thing, it would be, oh my God, we got policies, we got people to help, we got treatment centers, right? So when we really look at that framework of how we are sitting here in this, what I refer to as the war on people that use drugs, right? Because we can't have a war on drugs or these inanimate objects that we can't really fight. We're fighting the people, that have the most adversities, the most adverse childhood experiences, the most trauma, the most a need to not feel how they feel because the world inside of them or outside of them is so chaotic, right? So you can just look at our prison systems and what I said is true. They're so disproportionately with African American. And then if we look in indigenous communities with that Schedule I, like I said, no medical purpose, highly addictive, we have peyote, we have ayahuasca, we have psilocybin mushrooms, we have MDMA ecstasy. I think y'all have been around with me, maybe seeing some new data that MDMA ecstasy is severely helping PTSD in medical trials where they're doing MDMA assisted psychotherapy. Same with psilocybin, right? These substances are indigenous plant medicines, right? Who is highly addicted to peyote? And it's not because it's elite, right? I've worked in substance use care for 15 years. I've never had someone come into my thing and say, oh my God, you know what I mean? So again, we said, okay, indigenous folks, native folks that were here, we're gonna make your drugs way illegal. We're gonna put them as a Schedule I. So how we schedule drugs within our judicial system, it goes off of, is it that addictive? Does it have medical properties, right? So those are known as the most highly addictive ones, which I don't know. I agree with that because I see through why they're, why we're pointing these ones as addictive. So just, sit with that, know that information. You can cite it. You can find a lot of evidence on it. It's 100% the reality of how we've structured this. So it's unfortunate because there are so many folks, that are experiencing stigma and unable to get services because they might be of a different, color or use a different type of substance than, alcohol drinker that just goes there after work, right? But that person is still a person who uses drugs. They're using, we have this again, alcohol and other drugs. We've already said alcohol is its own thing. And then there's alcohol is a drug. It changes the way you think, the way, so it's we've already systematically said alcohol, but those other drugs, right? And that's when we other people and say those kind of people. You guys have no idea how many times I've given out NARCAN at a community event and I've had people come up and say, I don't hang out with those people. And I have to say, well, those people could be your teenagers. Because that is the leading cause of death right now, 14 to 24-year-olds is fentanyl poisoning. So how can you say those people, right? And then we just other people where it's wait a minute, that doesn't mean that they're worse because they chose this type of way to code. So I could go on and on. I'm gonna head to the next one just so in the lack of time. We have NARCAN, right, which is obviously overdose prevention. I really like to compare these to EpiPens, right? If somebody's in an anaphylactic shock and they had a food allergy and they're in a restaurant, someone could say, you did this to yourself, I'm not gonna do that, right? But we might say that to a drug user. It's well, they should have known better than to use substances. Why would I give them NARCAN? These are the things that I hear out in the community about people that I work with and care for and love, So it's unfortunate, but Santa Clara County's doing mass efforts we have destigmatizing campaigns, we've got naloxone efforts, we've got a lot of really great supportive services, but there's just so much stigma out there. So I encourage us all, I made 10 tips on working in harm reduction, and it's things like changing the narrative, talking, calling people out when they're using language, like discriminatory language against people that use drugs. Like, you can see what I'm saying, right? People that use drugs. I'm not saying addicts, I'm saying alcohol. Like, there's very stigmatizing language. When I say someone's an alcoholic, I'm not really talking about the person. I'm talking about the experience they might be having an issue with alcohol. No one's an alcoholic. No one's a schizophrenic. Someone is experiencing schizophrenia, right? So we really try to take the label away from, there's a human in here. Like, this isn't, we're not these labels that people will put on us, right? So we can move to the next slide. Got more to say, Cheryl. Thank you so much. So I touched on fentanyl, right? It's really saddening. When I was growing up, I did not have National Fentanyl Awareness Day on the calendar. So this is a really big thing happening, not in just our county, but in all counties. We do a lot of graphics at, the Q Corner, and put them on our Instagram. So this is something I like to show. This is the kind of stuff we do. NARCAN does work on fentanyl, right? I get that question a lot. Fentanyl is an opioid. It is a very potent opioid, but it responds to naloxone, luckily. Testing substances, highly recommended. We have access to fentanyl testing strips. What they will do is you can take your substance, saturate it in water, and you will put this testing strip in here, and it'll tell you if it's negative or positive for fentanyl. And that is all we really have right now in order for folks to know what they're taking, right? But the unfortunate part, I was sharing with some members before they left, that they don't get all the analogs. Since fentanyl we're not getting the fentanyl that's coming from a hospital, right? Where we know what's in it, so we can build a test to test it. Fentanyl is being made all different ways in our states right now with all different chemicals, so the test can't keep up to test all the analogs. So I can't say these are 100% effective, but they're the best thing we have. And I always say, if somebody tests it's negative, please also have NARCAN, because you never know. Also with pills, it's very important that you test the entire pill, especially, like, this really needs to be known to young folks, right? If someone comes up at a party and says, hey, I've got a pill for you, I tested it, that's false, because it needs to be saturated in water to be tested. There's a phenomenon called the chocolate chip cookie effect. If you think of a chocolate chip cookie, think of the fentanyl being the chocolate chips in that cookie. And I'm sure we've all taken a bite of one if we ever took a bite of a chocolate chip cookie and went, oh, there's no chocolate chip in that bite, it was still in the cookie. So that could be, if you just if somebody just tests a portion of the pill, there could still be fentanyl in the pill, right? And testing every pill might be like, oh, I'm going to get my pill 100%, crush it up, wet it. What now? Drink the water if it's negative, right? You're going to take it with water anyway. Because I get that, like, whoa, and I tell people that I don't want to wait. No, you're not going to waste your substance. You're just testing it to make sure that it's clear. This is the biggest myth that is probably one of the biggest killers for folks that are engaging in substance use is if you touch fentanyl, you can experience an overdose. That is 100% false. There's no finding in that. That was put out by the DEA in 2017. They put out a video. You've seen things, I'm sure, in the media of cops kind of having, oh God, and they fell out because they saw a powder, or they came in contact with one. It doesn't absorb in your skin like that in a powder form. We do have fentanyl patches, which are used for pain management, but those have been designed scientifically to absorb transdermally into someone's skin. I've never heard of anyone saying, take something, put it on a sticker, it'll go in your, you know what I mean? Like, really knowing that, like, there is possibility with fentanyl test strips fentanyl patches to absorb through your skin, but it's not possible to just touch something and it goes into your bloodstream. That was the scare tactic put out. And what's happening with that is it's keeping people from responding, because they might say, I don't know, do they have fentanyl on them? I'm not going to give them Narcan. There's no way I'm going to give them mouth to mouth. You know what I mean? But that thinking of how misinformation can just go and go and go, and it comes out from a source that I want to trust, the DEA, right? And there's been multiple studies and understanding, and toxicologists and medical professionals saying this is not, we don't have nurses, doctors, people working in labs with fentanyl that are having overdoses. When they tested these officers, there was no opioids in their system. What happened is they had a nocebo effect. It is something where you're told this is going to happen, and it's almost like a placebo effect, right? Mm-hmm. Where they did experience something that we physically saw, but it was increased heart rate, hyperventilation, falling out. That's panic. That's a panic response. When you're overdosing, which you'll learn, or poisoned by fentanyl, it's decreased heart rate, it's lowered breathing, and it's not immediate fallout. It's a process, right? So that's really I'm just bummed because I keep hearing it and hearing it from people, and I'm like, this was, you know, over 6 years ago it went out. We're just tirelessly trying to combat misinformation. So can move to the next slide because there's definitely more on fentanyl. This is, I shared some of it, you know, about fake pills. This is really what's a lot, the DEA, which I don't know what I just said if you want to trust the source, but the DEA said that they have been finding 70% of the pills that are not out of pharmacies are adulterated with fentanyl. So that is what's happening. Unfortunately, it really looks similar, right? If you look at that down there, they look very similar. I wouldn't know the difference unless I tested it. If you see the very bottom, that is an example of what test strips look like. The top part on that pencil, that is enough to kill somebody. That's how potent fentanyl is. And I'm going to clarify, it's enough to kill somebody that doesn't have a tolerance for opioids, right? If somebody is tolerant to opioids, they may have a safeguard if they come in contact, ingest some type of substance that has fentanyl in it. I'm talking about the kids that are experimenting, right? We have campaigns in the county like one pill can kill. There was a senior at Los Gatos High, if you guys ever get a chance to see this movie he created called Fentanyl High, it was in response to teens overdosing at Los Gatos High School. And so he took it upon himself to make this beautiful documentary, but I'm not kidding right now. The leading cause of death, 20% of youth, 14 to 24 that try substances are dying. It's insane. This is like really what is happening today in our country. Over 300 people have died from opioid injury and death already today in this every day. It's like we're having a 9/11 every 2 weeks. And we're just saying, okay, let's try to get NARCAN, you know what I mean? And it really has to come down with laws in our drug supply. Youth are at increased risk, Snapchat, Instagram, they're getting these on, you know, dealers will come, their window, throw it up, you don't even know if your kid just got something thrown up, you know, and I'm not trying to scare you, but if you have kids, please have conversations with them, please educate them. This is, you know, my teenager takes NARCAN and test strips to her high school, and soon after, she was a sophomore a couple years ago, one of her friends texted back and said, yo, thanks for the strip. My pill was positive. You saved my life. And it was just like, this is really happening. So I'm glad you all are, you know, here paying attention and really wanting to, you know, be a part of this effort. Pharmaceutical shortages, they increase overdoses, right? When folks can't get their medication, they might go to the street and buy something that isn't pure. It's a strong synthetic opioid, like I said. It's known to be about 50 to 100 times stronger than morphine. I don't know if that works with anyone if you don't know how strong morphine is. There's another fentanyl that is 1,000 times stronger than fentanyl called carfentanil, which they are recently starting to see in the drug supply here, that is for elephants, right? So it's about that body mass. We're not made like elephants, so even smaller than that dose up there is enough to, you know, put somebody into an overdose or fatally kill them. Wow. So it's being found in almost all of the substances, the street substances, including, and they're really the driver of increased drug overdoses and poisonings. And when you hear me saying the two different ones, right, we have poisonings because they talk about how, like that, when somebody's say buying a Xanax pill and they think it's a Xanax and they take it and it's laced with fentanyl, they've been poisoned, right? Like there's been cases of folks taking Adderall that were laced. Like a lot of these are teens, right? We live in this culture of take a pill, it will change the way you feel, this might help. So when it's outside of pharmacy, it can be very, very dangerous. We can go to the next slide, thank you. So what is naloxone? It's Narcan. So naloxone is the generic name of Narcan, right? So that's really like what the medicine is. It was produced 1961. It was available to combat overdoses. What year is it right now? 2024, and folks are going, whoa, what is this stuff, right? It's been around, but the thing is, it's stigmatized. It's to help people that use drugs. We don't want it out, you know, in the streets helping people. So this was the medication, you know, back in the day, you'd see a movie, someone would throw someone in front of the hospital, beep, beep, and drive away because they don't want to get in trouble because they have drugs on them or around them. That this is the medication they were using in the hospitals to revive these folks, right? With the efforts of harm reduction work, it has been put in the hands of folks that need it because the response time, right? We don't know if EMS wasn't even carrying it until, you know, the past decade or 15 years ago, because again, we weren't having this mass overdose crisis in our country. It is legal for everyone to carry. It is like first aid. There should be, this medication is so amazing that if you give it to someone and you don't know if it's Narcan or opioid related, it will not hurt them. It is simply designed to go onto the opioid receptor. This is how our opioids help our pain management system feel good, is it's the mu receptors, they like lock and key, right? This is how drugs work in our brain. You can eat something, it doesn't affect you. You can eat something else, that's because we have some type of receptor to catch that chemical in our brain. So this medication will go in when somebody is unresponsive and not breathing, and it'll knock it off the receptor and it'll go on that receptor so the drug can't reattach in the moment. So the medication only lasts 30 to 90 minutes. It's a huge gap window right there, I know. But in terms of in the system, like any medication, right, it wears off. So the unfortunate part is, because this is an emergency response tool, right? This is not, all right, one and done, you might be good for, you know, the rest of the day, is that the opioids can't metabolize out of my bloodstream that quick, right, in 30 minutes. So as soon as that medication, even if the person doesn't ingest more drugs, they're just known to just reattach right to the brain receptors, because that's why that's all they do when they go in the body. So it's really important that we give EMS a call. We could stay with the person if they deny service, because trust me, about 75% of folks I work with deny service because of the way they're treated when they are taken to the hospital. Because of being a person that uses drugs, very different if you're taken in for an alcohol poisoning, you know, it's just like, all right. So they deny service a lot because they've not been treated well, you know, in our community, meaning the 2S LGBTQ plus community, or in the people that use drugs community. There's a lot of intersection with the way the stigma is against our community and the drug user community. So yeah, it historically came intramuscular and intravenous, right? This is where NARCAN really came to be branded, is it's nasal. It's really easy to administer. Doesn't take a hypodermic needle in a crisis situation, and what do I do and how, which place do I put it? And God, their, you know, jeans are too thick, I can't get it in their thigh. This is, okay, you can put it in someone's nose, like I said, not have to know 100 to 1000% if this person is experiencing opioid related issues. So we'll go to the next slide, and we're getting into the training. I appreciate if I'm going over time.
Can it be re-administered if it's past that 30 minutes?
Yes, you can if you have more, you definitely can re-administer it 100%. Yeah, and that's why we say to stay with the person for up to 2 hours, because if it happens and you don't have the NARCAN, you will at least call for help again, and EMS will bring NARCAN, right? All of our EMS folks have NARCAN. But thank you for asking that, definitely. So what is an opioid opiate? Fentanyl is definitely one, because I spoke about that, but this is a class of drugs that are commonly called narcotics, right? It's heroin, opium, morphine, oxycodone, Vicodin, oxys, Percocet, fentanyl, methadone is even an opioid. So this is the class of drugs it works on, right? The thing though that we're seeing is fentanyl is being put into cocaine. So if you're like, oh, my friend just told me they were using cocaine and they're experiencing these symptoms, give them NARCAN, right? Because that's the unfortunate part, is people that aren't aware of this in the drug culture and the drug scene. I always think of like, oh, it's my bachelorette party, let's go get a bag like we were 20 years ago. Don't, or test it, because it's not what it was 20 years ago. The supply is not, it's not good right now. I don't think it will ever be.
Why are these manufacturers cutting?
Get there, definitely, yeah. I'll time for some questions, so I'll definitely get there, yeah. So signs of an opioid overdose poisoning. So this is what you're gonna look for, but before we go through this, I wanna let you guys know, there's a postcard on the table that has all of these signs laid out, all of these symptoms, and a QR code that will give you access to a training video, because I know I'm throwing a lot of information at you at once. So knowing, it's the one with the heart on it. Yeah, you just grabbed it, Cheryl. Thank you. We have it translated in Vietnamese. I didn't have any of our Spanish ones in the office, but we made it in the Lockstone training video in Spanish, one in English, and then we're hoping this fiscal year to make one in Vietnamese. Hopefully for all of our threshold languages in the county at some point. Accessibility is real, right? Folks can't speak the language I'm training in. I want them to get the information. So what we're gonna look for, these are the signs, right? But again, you don't have to 100%. If it's a diabetic coma, this person's not breathing, give them naloxone, you don't know, right? So you want to see if they're unconscious and unresponsive is the number one thing, right? Someone is not responding to you. They have slowed, irregular, or gurgling kind of breathing. You sound like choking, you know, they can't sleep apnea, like what's going on? Their skin color can change, blue or purple, gray or ashen, depending on their skin tone, looking around their cuticles, their lips, you know, their inner lip, their toes. If you're starting to see oxygen deprivation, that will be changing the color of skin. Cold, clammy, pale skin, it can appear like a seizure. I had a participant that we thought was having a seizure. We gave him 4 doses of NARCAN, they were good. Vomiting, It can also just, opioids tend to induce vomiting. So on the next slide, we'll walk through the steps of how to do it. And I'll tell you, it's not as hard as maybe we anticipate it to be. So first we wanna, if we encounter any of this, we wanna check to see if we can get this person to respond. Hey, buddy, can you wake up? Hey, hello, you know their name. Billy, come on, dude, come on. If they're not responding, maybe try to kick the bottom of their foot. The best approach is to take your knuckles and give them a sternum rub. If you do that to yourself, you'll feel pretty uncomfortable. That will give a little pain. Hey, I'm okay, you know. Someone should respond. If they're not responding, the first thing you want to do is, and they're not laying down, lay them down gently on their back. We always ask, please give them what we call the verbal NARCAN. If somebody is habituated to opioids and you say, hey, I'm gonna NARCAN you, they're gonna say no, because they will immediately go into withdrawals from this medication, because like I said, it will knock it off of the receptor, right? So I had a participant that would always be nodding out and be like, you need NARCAN? No, I'm good. no, I'm good, you know, because he knew, I want to be high. I do not want to be in withdrawals. So what did I do? I kept checking on him because I don't know if that's going to change in 10, 15, 20 minutes. You know, he usually just get out of the hallway, so I wouldn't keep bothering him. But just knowing that that is what, you know, and it kind of gives some informed consent. Hey, I'm going to give you this medication. If they don't respond, they're on their back, you tilt their head back, you're gonna open up your box and you're gonna have 2 doses that look like this. Rip it open, you're gonna tilt their head back and insert it into their nostril until you put your skin on theirs and then push that red card in. You've given them a dose. At that point, step back, call 911, use the language, I'm with someone unresponsive. We don't know if it's opioid related. If we do that language, we can maybe keep the PD from coming and we can keep the call time quicker. They'll come quicker if they gotta wait for PD, right? So just say, I'm with someone unresponsive, we need help, they're not breathing. If 2 to 3 minutes go by and this person hasn't started breathing, and it will be, you'll see them breathe, they will come back. If they haven't done that, give them another dose, right? We're saying with naloxone or with fentanyl, a little bit more NARCAN might not hurt because of the potency of the opioid, and we don't know how much someone ingested. So every 2 to 3 minutes, as much as you have, keep giving it to them until EMS arrives. If they haven't responded, after a couple doses, start to give them rescue breaths. We don't want brain deprivation, right? I've had so many folks come back from being overdosed, but they have stroke-like symptoms. Their cognition is skewed, you know, there's things like that. They survive, but they still have a lot of medical tendency. So we want to get that in them as soon as possible. Calling 911, give them mouth to mouth. If you don't know how to do that, EMS, hey, what do I do next? How do I help this person breathe? You know, give them chest compressions if they have no pulse. As soon as they start breathing, which is the best case scenario, and what we want is you want to quickly put them in the rescue position on their left side in this kind of cradling position. If they vomit, we don't want them aspirating, choking on their vomit, being on their back. Let them know EMS is on their way. Again, let them know, hey, when they arrive, yeah, we give NARCAN, you know, this and that. But in that moment, we don't need to give, we don't know, again, if it's opioid related at that time. Things to remember, there is an expiration date on your box. I have plenty of them. It works after the expiration date. However, best practice is come see us at the Q corner and get a new box. I think these are January 2026 or something. But if it's expired, still use it. It'll work. Stay with the person for up to 2 hours I spoke about. Naloxone can be given to anyone. Infants, elderly folks, teenagers, doesn't matter. Dogs. I've had participants come in and say, hey, my dog, you know, liked where I was freebasing and I gave him NARCAN, it works. So, you know, we really want to make sure people know about infants because we have had some, you know, in this county, some infants that had ingested fentanyl and unfortunately are not with us anymore. So knowing that, you know, it doesn't have to be a different dose, it works the same way in the brain. And don't worry, because there is a Good Samaritan's Law, right? This is legal to carry. Good Samaritan's Law protects you as the person that gives it to them. There's no liability. There's no, hey, you gave me this medicine without my consent. And it also protects legal concerns for folks, maybe if paraphernalia and stuff are on site, right? But I always say, know your experience with police. I can't say they're gonna treat you like I'm anticipating and training you to think they're gonna treat you. So, you know, always know your individualized relationship with PD. And what is my last one? It's being sold over the counter, right? So now the FDA's approved it for over the counter. The unfortunate part, it's about $80 to $120 for a box of 2 doses. So, you know, I know we've made great efforts, but you can get it to your local public health department right there at Linden, or come see us at the Q corner. And I also put a flyer out there that talks about different places in the county. There's vending machines around the county. There's other sites that you can get it. Scoop, Santa Clara County Opioid Overdose Prevention, can also send them to people at home, right? So if there's folks on this call that can't get access, definitely will leave you extra, doses for folks that you can just sign up and they'll mail you one at home. So we can move to the next slide, which I think is questions. And I appreciate y'all's time and attention. Oh, this is just the document that I shared about the 10 tips. Please pick one up. It really just talks about like, do no harm, celebrate every positive change, don't assume about people. Recovery, or excuse me, abstinence and harm reduction aren't individually exclusive. A lot of the stuff I shared here with you just in real snippets. So appreciate that. And then any questions or anything, folks? Yes, you wanted to ask about how is it getting into the supply, correct?
Right.
Yeah, so theories are potency, cheapness, right? It's like, I look at it honestly because I don't want to vilify dealers because they need to make living how they need to make. If we had drug regulation, that would be a very different scenario. We wouldn't need to have street dealers, get it from a pharmacy. It's really cheap to be made. It's really potent. Think of being in a capitalistic society. We know that cane sugar works better for us in our bodies, right? We use fructose corn syrup. You can use that at your own risk. You can deal with health complications in your past, right? But we know cane sugar, but it's more expensive, it's more costly, but it's better for the human body. I kind of think of it like that. We have mass production. People want to get their clientele what they need. So they want to buy a cheaper product. They want to put it in more doses and give it out to folks, right? But the reality is it was to make heroin more potent. In our county, 70% of the fentanyl is being found in heroin. So it was really about making mine more potent than yours, and it's cheaper, and folks want more potency of stuff. It was coming in from other countries in the beginning, and then we got a lot of regulations on that, so it's starting to be made really in-house here in the States. And then we have other things that are coming up like ISO, which is nitazene, which is a European opiate that is 100 times stronger than fentanyl. They're starting to see it in the county being shipped in online and stuff. So my question is, we talk about the supply and stop the supply. We need to really look at the demand. Why do we have so many people in our country in pain that don't want to feel the way they want to feel, that want to take opioids, that want to get out of their mind, that want to, you know what I mean? Like, it's all, if there wasn't demand here, there would be no supply, right? They're not having fentanyl crisis in the Netherlands. They're not having a fentanyl crisis. This like here in Canada are like the only places that are having a fentanyl crisis. I went to a conference and I was talking with people in London 2 years ago, and they're still talking about K2 and spice and all the synthetic marijuanas. That's what's happening in London. They were like, fentanyl, what? You know what I mean? But like, this is not a global trend. We have a need here in America. We want this stuff. So they're going to keep giving it to us, and until we can address our mental health services, our lack of, our decrease in adverse childhood experiences for folks and the way we treat people and not have them want to, change. I look at substance use as a response to human suffering. I don't look at it as a choice, a disease. People are suffering and this makes them feel better. They'll take it, So thank you for that. But yeah, it's just really about making it more potent, and there's no clear how is it getting in the supply, right? There's a lot of theories of, coming in from other countries, coming in from the cartel.
So it does have to be invested then. So when we're seeing it sensationalized in the news, the powder was found near the baby.
Yep.
It's not that it was that somehow the baby.
What do babies do?
Touch.
They put stuff in their mouths all the time, right? Because and I appreciate you saying that, right? Because language is so important when we're talking about this, because I've heard fentanyl exposure so many times. What's a COVID exposure? It's 15 minutes, 6 feet, right? My interpretation of an exposure is so different now that we've gone through COVID. So that's what I think, right? So when people say fentanyl exposure, there's the idea that plate right there in front of you has fentanyl in it. You are being exposed, right? That's not how it's happening. The children had to ingest it. They had, so that's really crucial in terms of language, right? Because I've seen this a lot, and that is used as weaponizing language against people that use drugs, because now they're trying to put a law in, or they may have already passed it. I need to check in that if you expose me to fentanyl, I can charge you as a police officer. So if I respond to you and we find it was fentanyl in your system, you exposed me and that was dangerous to me, so I can charge you with a crime. So it's really about, again, that war on drugs and keeping certain groups of people marginalized and ostracized and whatnot, because if you're exposed to fentanyl, nothing's gonna happen. I put my hand in, positive test results This tested positive for fentanyl, cool. Nope, yeah, my heart rate went up, that's what I've heard, you know what I mean, but again, that's not, so it's like these things are believed so much that it's unfortunate, you know? That, and then it gets out like that, we think, oh my god, if, I've had like people working at sites wanting hazard pay because they work at a treatment center and they're saying, if my client brings in fentanyl, I'm exposed to it, it's exposed to me. No, honey, that's not how it works. If you ingest it, if you use it, if it gets into your bloodstream, it's dangerous for you, you know? But thank you for that question, definitely.
So is this program at all working with the county Office of Education to provide more drug
We
education
do a
for
lot
children?
in the schools, yeah, we do a lot of NARCAN trainings, a lot of fentanyl trainings, right now. I don't know, it's a pretty high percentage, it was like, what, we have 37 districts in the county, 31 of them have NARCAN on site, you know, in terms of school districts, so yeah. But the reality is, it's not, you have to, it's, you know, there's certain legislation that's being put in, you know, the first one was administrators have to have it, right, like teachers, staff have to be trained. But let's be real, the kid on going to a Friday party, or you're gonna go to the teacher, like, can I get your box of NARCAN, I'm gonna go to a rave, this, you know, so we really want, again, it to get in the hands of people that need it, so we do a lot of like tabling events there, but at the county level, yes, and if you look at that flyer, the very first one, that where you can get NARCAN, the vending machine was at Santa Clara University. People want it, and it's not, you know, it's not about, I always say it's like insurance, right? You're probably not gonna use it, but if you have to use it, you're gonna be really happy you have it in your house, in your car, where you're at, you know, and a lot of what I'm hearing feedback with folks like, yeah, can I get another box? I was, you know, at a 4th of July event, and someone went, this kid's not breathing, and I had the NARCAN, so they didn't use it on their friend sitting next to them, or they're going out using drugs together, they were just a community member that had it in a space, right? So we're making sure that we are like, you know, going around community district, we did this in June, like, hey, you have NARCAN, it's Pride Month, you know, and just really going bar to bar, restaurant to restaurant, I'm gonna start hitting up hotels, hitting up casinos, like just getting it on site, because again, if you're the bartender and you've got the NARCAN here, someone says, this person, you know, it might be drug related, you know, so you're gonna go respond, so it's really about that global, like collective effort of really helping people,
There was
you know?
there was a Rotarian, I think it was a Cupertino Rotarian, you know, and she had it on her. Did no intention, she didn't think anybody she knew would need it, but someone came up to her and said, hey, do you have NARCAN? And it was nobody she knew, but she gave it to them and they were able to prevent an overdose.
See, thanks for sharing that, Renee.
Yeah, 'cause
Firsthand
it isn't-
experience,
you don't
right?
have to know anybody who's a drug user, but to
Yeah.
have it with you in case someone needs it. And it can be a complete
Right.
stranger, you know?
If you saw someone choking, you try to give them Heimlich, just because we're innate
Mhm.
humans, we're like, what can I do? Like, somebody
Right.
get this out of their throat, right? So it's like, we just do, that's part of our nature as human creatures, is like, we're compassionate, we wanna help, you know, mostly. You know,
Mostly.
there's some folks, you know, in certain areas that aren't, but you know what I mean, it's like, that's ingrained in us, so it's similar,
Is-
right? You would just see someone, what can I do to help?
Is there any legislation to make it a requirement to have on site in any business or restaurant? Like we have, it's a requirement that we have fire extinguishers
Yeah.
on site.
An
It
age-
Not
should
that
be a
far. We're
requirement
doing
that
more
we
like
have,
the county is saying you should, the county says that, you know what I mean, more in our
should
county,
be part
but-
of like the
Oh,
inspection
it
when the
should.
fire marshal goes through.
Yeah, and that's where, you know, a lot of this stuff happens is at those higher levels where we gotta call our council members, call our people and say, hey, we need this, right? Cause that's how they are doing fentanyl education to kids now. They're doing distribution at schools. It was a good thought, but you know, I'd call school, oh, I don't think we can do that here. And I'd say, actually, no, there's a law that just got enacted a few weeks ago that says you have to start doing this here. Because this is not, you know, so when those things, then we have like a leg to stand on, right?
Yeah.
So I like what you're saying in terms of that, you
I
know.
mean, it should just be part of the inspection. They
It
have them
should.
come
And
through.
first
Every
aid
2
kit,
years,
yeah.
they come in and inspect the fire extinguishers.
In
In
They're doing
every,
it now, they're doing the
Exactly.
AEDs now too.
Yeah.
There's a requirement for the number of employees.
So you being Rotarians, it sounds like your wheels are turning on what can we do and how can we as a community member make,
and in every
Kit on
first
another.
aid kit, the companies
Yeah.
have the first aid kits that get replenished
Right.
with the aspirin and
yeah,
the Band-Aids and the eye wash.
I have two in my car, but I just carry it with me in case, cause.
in case, right?
You never know.
You never know.
Never know.
You never know.
Yeah, so I thank you for your guys' time and your folks' time and your just curiosity about this and being kind of allies in it, cause it's hard work out there, cause we get a lot of pushback from folks, and I was gonna ask you, I don't know Did you guys have any pushback at the dog party?
Nope.
The
No,
security guards kept coming to our staffs. First they came to our
we were
staff.
selling beer, they didn't care.
They said, well, I don't understand why you have this addictive product here.
No, they
You know that's addictive? And
We
we were like,
complained,
what?
we heard that and we complained to the
Yeah.
We
security.
did too, yeah, but our staff kept telling, cause I wasn't at the event, but they did good. They were like, no, but it was just like, then again, one of the staff members said,
Yeah, we
they
had
did
security
trainings,
right
they
next
showed
to us.
a car.
Well, and that's what I told them right away, when
Yeah.
we heard
But
that,
I
I
think
told
it
them
was
right
one of the
away,
security
you need.
guards.
It was a
Really?
security guard,
Yeah.
yeah, and I was like, maybe you should actually
Yeah,
be
you
the
should know.
if only person that has this at a community event, because what are you gonna do? If someone said, I need someone to help me call 911, it's usually security that's gonna, you know what I mean? So I was just like, no way, so. But they got re-educated, right? But it's, again, that misinformation, and then they tell these people these, and then they believe it, oh. Said they
Well,
were.
and that's it, our park rangers all have them in their trucks, they
Yeah,
all have them
good.
with their, so, I mean, it's the same thing, if we made it so that it was a requirement to have it on site at any commercially operated business, same thing for security. Security carry their radios, they should be carrying their
Yeah, we
NARCAN.
plan on-
And you guys can also get signed up with the NARCAN distribution project at the
Okay.
state level and just order your own supply, in the meantime, let's help you out for sure, but like that would be, if you really want like access to it, you can do that.
Yeah.
Especially as a collective or as a Rotary, they
Yeah.
would totally send you all.
I know
access.
I know some of the other Rotary clubs are looking for more Narcan.
Oh, yeah,
Yeah, they are, so maybe we can do that and be kind of a conduit for some of them.
yeah, after I did SJ Rotary, it was about 2 weeks later, they're like, can we get more? There's more
Yeah.
people, and I'm like, whoever, please, like, I
Yeah.
appreciate it. We have postcards, I have,
Yeah, we'll get some of
coasters
these.
actually too. We made coasters with our training video because we throw them at bars. People say, oh, what's this? Oh, okay, Narcan, so we're just trying everything to like get the education out there and just get people to go, what is that?
Well, with their e-bill.
Awesome. There's also these that I brought that say I carry Narcan, so even if you just wear, what is Narcan? Oh, hey, my shirt, I do this, people are like, what is that? Because it's, you might have it and nobody around you knows, and you
Yeah.
say, oh, wait, or you're messaging, oh, this is a safe person, I might be able to share about my substance use, because you're promoting health and safety in the community.
So if any of you folks online would like Narcan, let us know and we can get it to you.
Oh,
Just put something in chat. All right, so are we ready to move on?
Yes.
Thank you so much, Tessa. I really appreciate it.
you.
Thank you.